start recording this here. So again, we'll talk first off the thoracic vertebrae and then the ribs, and what else do we have to talk about here? And the manubrium, the sternum. Okay, so first one is the thoracic vertebrae. We already know that we have 12 of them, and I know we talked about it when we kind of were going through the before talking about the spinal cord. So we talked about the cervical, thoracic, and lumbar, and how to differentiate between them. A couple of things that you want to keep in mind for the thoracic vertebrae are these little demi-facets. Okay, so I guess it's half French, half English, but it's demi-facets, where they're half facet joints, and facets means that are two parts of the bone that kind of glide against each other, okay? And this is where I have the inflammation, by the way, to come to think of it. And then we have these facet joints that articulate with parts of the rib. So for each rib, the rib will articulate, the head of the rib will articulate with one of these, and then the what we kind of call like the angle of the rib, and I'll talk about that in more detail when we get to the next slide, will be articulating right in this little portion. Okay, so I want to keep those two in mind because these are how the ribs will be articulating with our thoracic vertebrae. Okay, for the other parts you should already know, the body and the spinous process and the little transverse processes in the vertebral frame, and all of these are things that structures that we've already discussed previously. Now for a typical rib, and we have obviously 12 ribs, and we'll talk, I believe, in the next couple of slides about which ones actually go all the way from the back to the anterior thoracic area. Not all of them do. Out of the 12, 10 connect to the sternum through these costal cartilage. Okay, so this would be your posterior part of the rib. This is the anterior part. Again, the anterior part connects to the sternum through this costal cartilage, and the sternum is the chest bone in the front. The rib curves, as you can see, anteriorly, and then on the external surface, the surface that you would feel on the outside here, that is a very smooth surface. Really nothing characteristic going on there. But on the inner surface, there's a costal groove. And in that costal groove, it's on the inferior border of the rib, so not up here, it's all the way on the bottom. On the inside, that costal groove would have the nerve, artery, and vein, so known as the intercostal vein, intercostal artery, and intercostal nerve. And they go in that order from superior to inferior. We usually remember them as a VAN, so vein, artery, and nerve. Okay, we also have a tubercle. Is there another picture that shows this? No. So there's a tubercle on the outer surface, and that little neck and the head. Okay, this head will be articulating with the thoracic vertebra, and so with that tubercle. So those two parts are going to be articulating with the demi-facets and the facets in order to make that joint in the very back. So there's other pictures that can kind of show that a little bit better. If we zoom in onto this area right here, this is what we'll see. You can see that tubercle, okay, and again, the tubercle will articulate with the facet. And then you see at the head, you have these little two very tiny facets, and those are going to articulate with the demi-facets. So demi in French means half. Okay, and then this bigger facet or bigger tubercle articulate with the bigger facet in the thoracic vertebrae. Am I making any sense at all? Somehow I feel that I'm just saying stuff. Am I making sense? No? Okay. Yes? Okay. Thank you, Michaela. Thank you, folks. I actually needed to hear that. Okay. So now here are your 12 pairs of ribs. Okay, you can see here the very first one that articulates. Well, let's kind of introduce the little parts of the sternum. Okay, so you have the manubrium. That is this little part, kind of like a badge part on the top. Then there's the body, of the sternum, and there's that little xiphoid process at the very tip. You can actually feel the xiphoid process. So if you go all the way underneath these ribs, you can feel a little bony process that can be pushed in and out, and that is known as the xiphoid process. And sometimes, especially in kids, you do CPR. If you do it a little bit too hard, that xiphoid process breaks. Okay, so you want to, be careful when you do that. So again, we have the manubrium on top, and then the body of the sternum, and then the xiphoid process in the bottom. You'll see here that the first rib articulates with the manubrium, and then from the second rib all the way down, well, let's talk about 2, 3, 4, and 5, and 6. Those articulate with the side of the body. And then 7, 8, 9, and 10, you see that their cartilages all join together. They combine together to make a bigger cartilage, and then they articulate with the sternum. So they don't have individual cartilages like these ribs on the top do. They rather have one big cartilage. They unite together, and again, they would articulate together to the manubrium. That's why we call them false ribs. Okay, so like in order to be a true rib, you would have to articulate with your own costal cartilage to the manubrium somewhere. Okay, being a false rib, which are the last 5 ribs, so that would be 7, 8, 9, 10, 11. Oh, sorry, 8, 9, 10, 11, and 12. So the last 5 ribs are known as false ribs because, again, they do not have their own costal cartilage articulating to the sternum. Now, the very 2 on the bottom, 11 and 12, those are now called floating ribs. Those don't even go all the way to the front. So they're just found on the back. They do not curve all the way to the front of the chest. And again, they're known as floating ribs. And if those break, those are the easiest to break, obviously, because they're they're literally just floating in the back. And if they do break, they can easily rupture a spleen or a kidney, and they can lead to a lot of internal hemorrhage. Now that's the sternum. Remember, we talked about the manubrium on top, then there's the body of the sternum, and then the xiphoid process. You can see here the very top of that badge, this is where it would articulate with the clavicle. And so it would be, remember we talked about the sternoclavicular joint, that is the part of the sternum that enters into that joint. And right underneath it, you have the attachment for the first rib, and then attachment for the second rib, and you keep on going. For those 7 true ribs, okay, and then the remaining 5 again articulate together in that one joint, in one costal cartilage. Oh, a couple of other things I want to know here. We've got this jugular notch on the top, and that again you can also feel. So if you put your fingers right under, kind of like at the beginning of the chest, there is a groove, and that is known as the jugular notch. So that is a bony part that you can actually feel. You can also feel that sternal angle, also known as the manubriosternal point or manubriosternal joint. That sternal angle is the angle between the manubrium and the body. Okay, so these are just little landmarks that they're known as surface anatomy. So you could see these anatomical landmarks on the surface of the body. Any questions, folks? Everybody's fine? Okay, I will take that as a good sign and keep, okay. Where is it? Where did it go? Okay, now for costal transverse joints, and those are, sure, why not? Everybody should have the right to learn, and every dog should have the right to learn too. Where is he or she? Put her on video. Oh, she's so cute. Hello. Is it a he or a she?
This is Nala. She's a she.
Hi, Nella. She's like, what am I doing here?
Now she's gone.
And she's off. But that's really cute, though. That would be nice if you could just sit home and relax with our, pets or kids. And as you guys know, I only have the fish, which one of them died, by the way. So I only have one fish. We need to go get more. But going back to our joints, we've got the costotransverse joints. Those are synovial joints between the tubercle of the rib and the transverse process of the vertebra. So how do these ribs actually articulate with the vertebrae in the back? So right here we have the head of the rib, and that articulates with the two demi-facets found on the vertebrae, one on top and one on the bottom. And so each rib will articulate with two vertebrae. And then the transverse process articulates, the transverse tubercle articulates with the transverse process of the vertebrae on the bottom. Okay, so these two right here, again, there's one on top, one on the bottom, and the head of the rib articulates with them both. But this part, that tubercle will articulate with the transverse process of the vertebra on the bottom, the inferior vertebrae. Okay, so you can see it here, the head articulating with both, let's just call them T3 and T4, while the tubercle will articulate with the transverse process of T4. Okay, so are we all clear on how that works? If not, let me know, okay?
Yeah, that makes sense.
Okay, perfect, thank you. That is the skeletal framework for the chest wall. We've got the ribs, the sternum, or all three parts of it, and we also have the intercostal vertebrae and the vertebrae in the back, or intercostal. I want to say the costal cartilages. I'm sorry, costal cartilages and the vertebrae in the back. Okay, do you see the clavicle on here, folks? Okay, so the clavicle is not included in the skeletal framework of the thoracic wall. Okay, the clavicle is considered part of the pectoral girdle, which is technically part of the upper limb. So the clavicle is a bone of the upper limb, and that's why when we learn or when we taught about the upper limb, we included the clavicle there. But when you're talking about the thorax, clavicle is not in the picture. Okay, so we're talking just mainly the ribs and anything attached to the ribs, so your manubrium and the vertebrae in the back. Okay, so just keep that in mind because that is kind of like an important board question that comes up a lot on is the clavicle part of the thoracic cage or not? So that was a little bit about the bony processes, the bony parts of the thorax. Now we'll talk about some of the muscles that we are supposed to be learning about today. And the biggest of them are the pectoralis major. Okay, and the pectoralis major really covers the whole anterior chest wall. When you open up a cadaver and you remove the skin and then the fat, the very first muscle that you are going to meet in this area would be the pectoralis major muscle. And the pectoralis major muscle has its insertion in the humerus, so it is going to move the humerus. And the main joint that it moves would be the shoulder joint. What we used to do in real cadaver dissections, we would make an incision along that medial border and then reflect the pectoralis major laterally. When you do that, kind of like what you see here on this side, so we cut the pectoralis major. Underneath it, you could see another pectoralis muscle called the pectoralis minor. Now, the pectoralis minor gets its origins from the ribs and inserts into the coracoid process of the scapula. Remember when we talked about the medial and lateral pectoral nerves, we said that these nerves innervate your pectoralis major and pectoralis minor. And then there's a very tiny muscle, which I don't even think you can actually see it on here. It's so tiny, right underneath the clavicle, called the subclavius muscle. Those are the muscles of the pectoral region. So you have your pectoralis major, pec minor, and then the subclavius muscle. Okay, subclavius muscle is a very minor muscle. Really, we could survive without it. It does help, though, with inhalation if we need to use it as an accessory muscle of inhalation. But again, it's not like a major muscle that has major functions. Okay, so are we all good on those? Now here you can see, bigger, lots and lots of more muscles. So you can see here the pectoralis major muscle. Underneath it again, the pec minor. And I brought this picture so you could see the serratus anterior. So serratus means serrated or digitations, like finger-like projections. And you can see here that the finger-like projections of serratus anterior are kind of intermingling with the latissimus dorsi. So remember, the latissimus dorsi was all the way in the back, while the serratus anterior is actually, it's kind of takes part of the sides and part of the upper portion or the side of the chest wall. Again, there are digitations, and then it has its insertion into the humerus as well. Okay, so that right here, those digitations that you see from the front, that would be your serratus anterior muscle. You can also see it kind of like on this side after removing the pec major as well. The abdominal muscles, I'm not going to talk about those now because that has its own lecture, or its own lab. We'll worry about it when we get there. But for here, you want to know your pec major, pec minor, subclavius, somewhere hiding underneath the clavicle. We already talked about the deltoid muscle in a previous lab. We added the serratus anterior. Any takers on what this muscle would be right here? Anyone, folks, wants to kind of?
Is it brachialis?
That is, well, you'd have to remove this muscle to see the brachialis. It has two heads. Does that help? Two heads, biceps, correct. Biceps. So the muscle in the front here would be okay, here, let me do it this way. Muscle in the front here would be biceps. Muscle in the back with three heads would be triceps. Okay, so you have your biceps in the front, triceps in the back. And you can see here the two heads of biceps and I don't know if we broke it down into short and long heads, but you could see both of them here on the image. I believe in the list it just pretty much was biceps. For the students that were saying that is the brachioradialis is deeper to this, so you'd have to remove that to find it. The long head is more medial. The long head is the one that is more medial, yep. But like I said, for lab, I don't believe it was on your list to differentiate between long and short head. So you could just, biceps works fine. Okay. Now for the other muscles of the pectoral region, we already talked about the serratus anterior. So why is it still on the slide? Because this is not what I'm talking about here. So I want to talk about the muscles that are in between the ribs. In between the ribs, we have three layers of muscles, and they go from superficial to deep, the external intercostal, internal intercostal, and then the innermost intercostal. So it looks like they, somebody discovered the external and internal intercostals, and they were like, oh my God, there's a third layer. Now what do I call it? So I was like, okay, we'll just call it innermost. I don't know. That's just my story of how they invented that name. And it seems like there's no no imagination whatsoever in naming these muscles. But the external intercostal, if you look at the couple of things that would help in differentiating which muscles we're looking at. So we have the direction of fibers and where the muscle is. So the external intercostal are obviously the most external fibers, but honestly, in some of the videos that we're going to be watching, it's hard to tell 3D, so you can't really tell which one is deep and which one is superficial. So you want to look at the direction of muscle fibers going from bottom to top. If you see that they're going towards the outside, okay, that would be external intercostal. This would be the left side of the cadaver. Okay, so right here would be medial, while this would be lateral. So if the arrow, if you follow the direction of the muscle fibers from bottom to top, and it is going towards the lateral, so going towards the external part of the body, so that would be external intercostal. If you follow again the fibers from bottom to top, and it's going towards the inner part of the body or toward medially, that would be internal intercostal. Well, the innermost are pretty much very, they're longitudinal fibers, very hard to get those confused with the internal and external intercostals. When we watch the movie, there's another way, but I can't really show it on here, but I'll explain it on maybe myself. So the external intercostals show more on the lateral surface, while the internal intercostals show more on the medial surface. So if you're getting some muscles in the intercostal area, if the fibers are lateral, those would be your external intercostal. If they're medial, they would be internal intercostal. Okay, so a couple of different ways to help depending on which image you're looking at, or how clear the picture is. Okay, so are we all good with those three muscles so far? Okay, one more thing. Okay, again, kind of. Okay, so let me know if you need me to repeat it all over again, okay? So one thing to keep in mind here are your serratus anterior fibers. Again, those digitations that are coming off of the ribs, those are your serratus anterior. Okay, so these muscles again, does anybody need me to go over that again? Thumbs up, down, nothing. No, it's okay. Okay. And we're not going to go over this image that keeps on haunting us all the time, but I just have it up there for the lateral and medial pectoral nerves because they are going to show up again in the next slide since we are talking about the pectoral muscles. So these are the origins again of your lateral pectoral nerve from the lateral cord, medial pectoral nerve from the medial cord, and then as they show up superficial, you can see here that is your pectoralis major muscle. You can see these two nerves that are coming in to innervate them. So if you follow those nerves, they are innervating the pec major. At this point, you've got the lateral pectoral and the medial pectoral nerve. And I believe, was it in a video or some other source, maybe the VH dissector, I don't remember, we've also seen those two nerves. And I just have these circled here as well to kind of show you the long thoracic nerve. That is the nerve that you would find going straight down along the serratus anterior and along the latissimus dorsi muscle. So if you find a nerve that is on the side of the chest and it just kind of goes, straight downwards, that is your long thoracic nerve. Here again, you can see the muscles of the chest wall again. So we have your external intercostal, then the internal, and then the innermost. And what I've got new here are the intercostal structures that you can see. So remember we were talking about that costal groove in the rib, I don't know how many slides ago. Why does my computer not want to listen to me? I will do it this way then. So remember we talked about that costal groove right here. We said it has the intercostal blood vessels and the intercostal nerve. Now that is what we are looking at in this image. So you can see here, again, from top to bottom, we have the intercostal vein, artery, and then nerve. So the van, you can see here, is found in the intercostal groove or the costal groove of the nerve of the ribs. And it is towards it's on the posterior surface, or the dorsal surface, makes more sense. The dorsal surface of the rib. Okay, the transversus thoracis, I'd rather show it in another picture. Hopefully okay, it'll come up in another picture. Now this, what you are looking at, okay, so try to imagine yourself in the cadaver lab, okay, and we dissected, you made incisions on the sides of the cadaver, and then you made an incision all the way on between the chest wall and the abdomen, and then you flipped the chest wall. Okay, so you've opened the chest wall. This is what you are looking at. So this is the anterior chest wall, but you're looking at it from the back, the posterior view. So is everybody clear on kind of how we're looking at this or not? I could show you something, I could show you a video really quick if you're not clear as to what on earth we're looking at here. Just give me the cue and I will show you. Chest wall. Okay, let me see who's saying what. You're good, you're good. Is everybody good? Okay, so, okay, perfect. So the anterior chest wall, that again is your posterior view. When you look at it, you can see now the transversus thoracis muscle. That muscle you could only see from the posterior view. It's not something that you could see on the outer chest wall. Okay, other things to keep in mind here would be these blood vessels that go up and down. Those are known as, it actually has two names, so either the internal mammary blood vessels or the internal thoracic blood vessels, artery and vein. And those are branches off of the subclavian. Those are going to go down, longitudinally down. You can even see them down over here. And those are going to supply, like, they'll give out different branches to supply, to make those intercostal arteries. Same here on the other side. Okay. So those are your internal thoracic or the internal mammary arteries and veins. And somehow I think there was another picture to show them as well. Maybe I'm wrong. Oh, there's another one. Okay, good. Okay, so here again, you can see those internal thoracic artery or the internal mammary artery. The old name is the internal mammary, and the newer name is the internal thoracic artery. And one of the, does anybody know the clinical importance of these arteries? So they're used in bypass surgery, so coronary graft bypassing. We could take, parts of these arteries and use it for that. Okay. It's also used in breast surgery, breast reconstructive surgery, and that's why the older name was mammary artery, but because it's related to the thoracic wall, it has been renamed into the internal thoracic artery. Okay, so we're good on that, and they're branches off of the subclavian. Here again, you can see the blood supply of the chest wall where you got the intercostals, and you also have the artery and the veins. So you can see the veins draining into a couple of veins, which is different right from left. Okay, so on the right side, we have the azygous vein. On the left side, we have the hemiazygous vein. I've heard it azygous vein as well, but I've been pronouncing it azygous for 300 years. So I'm going to keep on pronouncing it azygous. There's a picture that'll show you both of those veins, because again, you want to make sure that you understand that the venous drainage on the right side drains into the azygous vein, while those intercostal veins on the left side drain into the hemiazygous. So hopefully that picture shows up somewhere next. Kind of. Okay. So those blue veins that you see, those are your intercostal veins. And again, on the right side, they drain into the azygous vein. On the left side, those are your intercostals, and they are going to drain into the hemiazygos. So it's a smaller one, half of the azygos, and then the hemiazygos drains into that bigger one, the bigger azygos vein on the right side. So it does cross over to the opposite side. That green structure that you see, that is the thoracic duct. Okay, and I don't know if you can actually see that. The yellow structure is the sympathetic chain. There's a sympathetic chain on the right and on the left, but the thoracic duct is just one structure, pretty much in the middle. It's a little bit usually to, one side. It's not really right in the middle. So the good thing is that we can color code them for you guys on an image, but we could not color code it for you on the real cadaver. So it'll pretty much just be gray strings of things going down the posterior chest wall. Okay, so again, your structures in the posterior chest wall are the sympathetic ganglia on both sides. In the middle, you have your thoracic duct. Then you have these veins, the azygos on the right and the hemiazygos on the left. The arteries, okay, so I just kind of circled the ones that are important, at least for today's lab. We have the ascending aorta, and then the arch of the aorta, and the descending aorta. I'm not sure if on your slide or on your list, does it say abdominal and thoracic descending, or is it just descending? But for reference, the descending aorta, if it's in the chest area, it's known as the descending thoracic. When it perforates or penetrates the diaphragm and gets into the abdomen, it is now known as the abdominal descending aorta. So it just depends on where it is in the body. Is everybody good on that little portion up here? On how we named them? So we had the right subclavian vein and the internal jugular vein to make your brachiocephalic veins. Now both brachiocephalic veins unite to become your superior vena cava. And here you can see the ascending aorta and the arch of the aorta. And then the descending aorta is really behind the heart, and that's why it's kind of, fading away. You can't really see it. But then it emerges underneath the heart again. The branches off of the arch of the aorta, you have your brachiocephalic trunk that will divide into your right common carotid and right subclavian. And then you have your left common carotid and left subclavian. So these are things that are going to come up for us on our quiz for today. So just a quick, kind of memory refresher. All the different parts, all of these vessels in the heart, that has, again, its own lab. So nothing I'm going to worry about today. We'll worry about it later when we have to. For the breast tissue is separated from the pectoralis major and minor. So we have, you can see here the ribs with all of the intercostal muscles. And then we have the pec minor and pec major. And then there's a fascia. That fascia is known as the pectoral fascia. And that, again, separates all of these muscles from the actual breast tissue. And know that whether male or female, we all have breast tissue, okay? Just depends on the hormones whether the breast tissue is going to enlarge or not. Breast tissue is made out of mainly adipose tissue and the mammary glands. Okay, so again, male or female, we all have adipose tissue and mammary glands. Again, depending on the hormones, these mammary glands either mature and enlarge or they do not. These are what the mammary glands look like when they're resting, so no lactation is happening at this point. This is what they look like when they are engorged or full of milk, and this is what they would be looking like during lactation. In between the fat tissue, we have these little suspensory ligaments, and those suspensory ligaments kind of radiate out from the pectoral fascia all the way down towards the nipple, and those are to support the breast tissue. Okay. Now for these mammary glands, they all have the lactiferous ducts. So if there is milk that is going to be being exit out of the breast, it'll go through the lactiferous duct, and then it'll stay in this what is known as a lactiferous sinus. So a sinus is a bigger, kind of like an enlarged area, and that will really be where milk will be stored until lactation or breastfeeding actually occurs, that would stimulate the lactiferous sinus to contract, so those smooth muscles would contract, and that would lead to the discharge of milk. A couple of things to keep in mind, like clinically speaking, is that if somebody has a breast mass and the breast mass is freely mobile, meaning that it is not attached to the pectoralis muscle, that is a good sign in a couple of ways, where it's either benign, or even if it is a malignant tissue, that means it did not invade the deeper tissue. A bad sign, though, or a red flag, would be if there's a breast lump that is not mobile. It is now attached to the pectoralis muscles. That means that it invaded the pectoral fascia and is now starting to invade the pectoral muscles. Okay, so that again is kind of like a red flagger that this is a metastatic tumor. Okay. Any questions, folks? Everybody really good, or is everybody just okay, we just want to get this done and over with? Which I wouldn't blame you, to be honest, but I just want to know. Be honest. And really, Mario? Serious? Okay, I'm gonna believe you. Okay. I'm stressed about the CM exam. I'm sorry, I don't know what to tell you. I'm not sure. It'll be done and over with. I don't know. So grad school, you just kind of want to dive in, and you know how when you take a dive and you come out for breath later on, so that's kind of what you want to do for the next couple of years. Exactly. So yeah, the first couple of years are tough, I'm not gonna lie, but it'll be all worth it eventually. So there is light at the end of the tunnel. Just keep your eyes on that light, okay? So just keep on moving forward. Trust me, it'll go by fast. You'll have no idea. You can't see it though. It's there. It's there. It's there. It may be foggy nowadays because of all the tests and everything, but it's there. So I got 2 more slides and I'll stop talking. Okay, I promise. So there's a couple of recesses so a recess means not recess, it's not a break. Okay, a recess would mean that they're like pockets. So the pleura, as it reflects, so the pleura would be on the, whether the parietal or the visceral pleura, the parietal pleura will be attached to the chest wall and the visceral pleura will be attached to the lung. And where it reflects, it will go down on the chest wall and then reflect back up on the lung. And that reflection leads to a pocket. And that pocket is known, all the way down here, is known as the costodiaphragmatic recess. Because it is a recess, or a pocket, between the diaphragm and the ribs. And another pocket is known right here between the ribs and the mediastinum, and that's known as the costomediastinal recess. They are clinically important, especially this costodiaphragmatic recess, because if anybody is going to get any kind of fluid in the pleura, so pleural effusion, that fluid by gravity is going to go up, fill up that costodiaphragmatic recess first. So if somebody gets an x-ray and that recess is just totally blacked out, that means that there is fluid, or no, it should be black. If it's all filled up with fluid, it'll be kind of grayish in color and obliterated. So not having a clear costodiaphragmatic recess is a cause of concern, because that means there's some fluid accumulating in there. That fluid could either be effusion or blood or whatever. They would have to figure that one out. Another thing that they would do, if there is fluid accumulating, you can put a tube in there. You want to put it all the way where it's dependent. So you don't want to put the tube up here, because again, by gravity, any fluid will be in this recess. So that would be where you would insert an intercostal tube. Okay, and so here you can see that costodiaphragmatic recess, that green structure that is highlighted for you all the way down here. Okay, so that ends my presentation, and I could stop talking for a minute. Any questions, folks, on that? I'm going to take that as a no. Okay, yeah, that's what I thought. And Okay, so let me share my. Was there a question or is there anybody saying? Okay. Window. Okay, so here's an open buffet of videos. Which ones do you want to watch together first? Like, we don't want to watch anything. Okay, just leave us alone. Okay, but let's watch maybe 2 out of these, and then you guys can watch the rest on your own. So I see Bones. You're like, we don't care, just pick one. So Bones, okay, we'll do Bones then. And yeah, I've got to share it with the audio. So give me a moment, folks. If you can't hear it, let me know.
The thorax is commonly known as the chest. In this section, we'll be looking mainly at the musculoskeletal structures of the thorax and at its principal blood vessels and nerves. We'll also look at the breast. We will see the lungs and the heart, but only briefly. They'll be shown fully in Volume 5 of this atlas. We'll start, as always, with the bones. Then we'll look at the pleural membrane, then at the muscles, then at the blood vessels and nerves, and lastly, at the breast. The bones of the thorax are the thoracic vertebrae, the 12 pairs of ribs, and the sternum. Connecting the upper 10 pairs of ribs to the sternum are the costal cartilages. The first rib is quite small. Like all the ribs, it's angled downward from back to front. We'll take a special look at the first rib in a little while. From the first rib to the third, the thorax widens in the shape of a dome to about 2/3 of its full width. From the third rib to the seventh, the thorax widens a little further in the shape of a cone. From the seventh rib to the 12th, the thorax narrows slightly and the ribs become very much shorter. The sternum, commonly known as the breastbone, consists of 3 parts: the manubrium, the body, and the xiphoid process, or xiphisternum. The manubrium is attached to the body of the sternum by a cartilaginous joint, at which a little movement is possible. There's a slight angle between the manubrium and the body, the sternal angle, that's easy to palpate, as is the upper border of the manubrium. The costal cartilages form a series of flexible, springy links between the ribs and the sternum. The first costal cartilage articulates with the manubrium. The second one articulates with the joint between the manubrium and the body, and the third to the 6th or 7th costal cartilages articulate with the body. Here's what the costal cartilages look like in the living body. They're quite flexible. These are the costochondral junctions, where the cartilages join the ribs. The lowest 4 costal cartilages, the 7th, 8th, 9th, and 10th, join onto one another in series, forming the costal arch. The angle between the 2 costal arches is called the infrasternal angle. The xiphoid process projects downwards in the infrasternal angle, where it can easily be palpated. The 11th and 12th ribs aren't attached to the costal arch. Since they're not linked to the sternum, they're called floating ribs. Ribs, sternum, and costal cartilages form an expandable container for the lungs and heart. This large opening, formed on each side by the costal arch and the last 2 ribs, is called the inferior or lower thoracic aperture. It's almost completely filled in by the diaphragm, which separates the thorax from the abdomen. Much smaller opening above, it's formed by the manubrium, the first ribs, and the first thoracic vertebra, is called the superior or upper thoracic aperture. Now that we've looked at the thorax as a whole, let's take a look at a typical rib, the sixth rib. The rib is thin and flat and curved in the form of a spiral. At the back, there are two thickenings, the head and the tubercle, which are separated by the neck. The curvature of the rib is interrupted by this angle, which marks the insertion of the iliocostalis, a back muscle that we've seen already. At the front, the end of the rib is hollowed out for the attachment of the costal cartilage. The outer aspect of the rib is smoothly curved. Its inner aspect is marked on the underside by this groove, in which the intercostal vessels and nerve run.
Okay, so that was the one about the bones. The second one that I want to show you folks would actually be, how do I unshare? Hold on. So the second one, because we really haven't, I didn't really mention them, and those are the nerves of the thorax. So on your list, you'll find the phrenic nerve and the recurrent laryngeal nerves. Those were not on the slides that we discussed earlier today, but okay, so I didn't like ignore them on purpose. They just show up again when we talk about the neck, and they show up in a clear, clear images on there. But because it's on your list for today, I want to show you that in this little video. I'll trust you folks to watch the breast muscles of expiration and muscles of inspiration, unless you want us to watch it together. I really have no problem with that whatsoever. I just really think that I'd rather, invest the time together in doing things that you can't do on your own. So for example, going over material from last week and addressing any questions from this week. But again, if you want to watch them together, I absolutely have no problem with that. Just let me know. Okay, so let me start this. And then share.
Now that we've looked at the arteries and veins of the thorax, we'll move on to look at the nerves. The nerves that we'll see are the phrenic nerve, the vagus nerve, sympathetic trunk, and the intercostal nerves. We'll look at the phrenic and vagus nerves first. The phrenic is the motor and sensory nerve of the diaphragm. The vagus provides the parasympathetic supply for all the organs of the thorax and abdomen. The courses of these two nerves are similar. They both start in the neck, run downward in the mediastinum, and pass through the diaphragm. We'll look at them first in the neck. In this dissection, the clavicles and the sternocleidomastoid muscles have been removed. Here's the phrenic nerve. It runs down on the front of the anterior scalene muscle and passes in front of the subclavian artery and behind the subclavian vein. To see the vagus nerve, we'll retract the internal jugular vein. Here's the vagus nerve.
Can I just mention something that as you're looking at these images, you want to, these are perfect images that could be used on the test. I'm not going to lie. Like that internal jugular vein is screaming that it's a vein. See how blue it is? A nerve that is going up and down right by that by the internal jugular vein is, you have really no other options but it being the vagus nerve. So Again, we will be going through a whole lab for the neck area, but since it's on the videos that are up for today, it's still kind of fair game to be on there, to for things that we would have to be familiar with. So vagus nerve, you guys remember that it's a cranial nerve, right? Okay. You guys can still hear me, correct, or no? So you guys can still hear me, right? Okay, perfect. So the vagus nerve is a cranial nerve. It's cranial nerve number 10, which means it's coming all the way from the brainstem in the head. It goes all the way down to supply the thoracic organs and the abdominal organs. It has parasympathetic supply. So it's a very, very long nerve. And in order for it to go from brainstem to thorax and abdomen, it would have to pass in the neck. In the neck, it is a whole nerve, as you can see in that video. But when it reaches the abdominal area, it starts branching off into smaller branches. That's why when you want to see the vagus nerve and identify it, we will do that in the neck and maybe in the upper part of the chest before it starts to branch off. Another nerve that might be going up and down, or there will be branches off of the vagus nerve actually, and that would be the recurrent laryngeal nerve. So that's another nerve that's on your list. It branches off of the vagus on either sides, whether right or left. But the course is a little bit different, so we'll see that in the video right here. The recurrent laryngeal obviously supplies the larynx, so that right here is the what is commonly known as Adam's apple, or the laryngeal prominence. And the recurrent laryngeal nerve is called recurrence because it originates all the way down here and then has to loop and go back up. Okay, so hence the name recurrent laryngeal. The looping, though, is different from right to left, and that's what you would have to know for actually both lecture and lab. So let's, complete this video and see what this guy tells us.
It lies behind and between the internal jugular vein and the common carotid artery. It passes in front of the subclavian artery. On the right side only, the vagus gives off this branch, the recurrent laryngeal, which curls around the artery and passes upwards to the larynx. To follow these two nerves, we'll remove the anterior chest wall. Here's the phrenic nerve. Here's the vagus nerve. The phrenic nerve passes behind the subclavian vein, which has been divided here, and runs downward in the mediastinum, in front of the root of the lung, close to the superior vena cava and right atrium. The phrenic nerve passes through the diaphragm. In the intact mediastinum, the phrenic nerve runs here, just beneath the pleura. On the left side, the course of the phrenic nerve is similar. In its course in the mediastinum, it passes over the aorta, the pulmonary trunk, and the left ventricle. To see the course of the vagus nerves, we remove the brachiocephalic veins and the superior vena cava. On the right side, the vagus nerve passes downward and backward, close to the trachea, to reach the esophagus. It breaks up into several branches as it runs down along the esophagus. On the left side, the vagus nerve crosses the arch of the aorta and passes backward to run down alongside the esophagus and through the diaphragm. On the left side, the recurrent laryngeal branch is given off here and curls around the arch of the aorta to return to the neck. Now we'll look at the intercostal nerves and at the sympathetic trunk.
Actually, before we do that, a couple of things to keep in mind from what we've seen already is that any two nerves that are going straight down the neck, those have two possibilities. It's either the vagus nerve or the phrenic nerve. So the phrenic nerve is the one that's going to supply the diaphragm, while the vagus nerve is the one that is going to start giving out branches because, again, it supplies parasympathetic to the thoracic and the abdominal. So I want to go to, there's this really nice point point where you can see both of them together. So right here, did everybody see my pointer, or is it not clear for you guys? Just a quick yes or no from anybody. Can anybody see the pointer as I move it on the image? You're gonna make me go back and see. Okay.
We can.
Okay, thank you. So the one that is on the lateral side, that is the phrenic nerve. That phrenic nerve will go all the way down to supply the diaphragm, while the one that is medial, that is the vagus nerve. Okay, so vagus, again, is going to give parasympathetic supply to the thoracic and abdominal. You can see it already starts to branch off. That right here, that little tiny twig on the bottom, that is the recurrent laryngeal nerve on the right side. And it arches underneath the subclavian. Okay, so the one that's already giving out branches in the chest would definitely be your vagus, while the one that runs all the way down until it reaches, so here again, you can see it going all the way down, no branches there whatsoever. That would be your vagus nerve. Where is it? There we go. All the way down, no branches. It only supplies the diaphragm. So that muscle that you see on either side, that's the diaphragm. It just looks dome-shaped because underneath, if you remove the diaphragm here, you'll find the spleen. Well, if you remove it on this side, you'll find the liver. So that kind of gives it that dome shapes that you could see on either side. Here again on the left side, you can see two nerves going down on the left. The one again going to the diaphragm is your phrenic, while the one that starts to branch off and kind of disappears on you, that's your vagus nerve. The vagus on the left will give the recurrent laryngeal, and the recurrent laryngeal on the left would have to loop underneath the arch of the aorta. Right? So remember that recurrent laryngeal has to loop underneath something in order to go back up and supply the larynx. Right anatomy is a little bit different from left-sided anatomy when it comes to blood vessels. So on the right side, it'll loop under the subclavian, while here you can see it looping underneath that arch of the aorta. So this is the ascending aorta, that's the arch, and you can see the descending in the back. Again, looking at these two nerves, this one goes all the way down, no branching, no looping, nothing. It really has one mission, and that is to supply the diaphragm. Excuse me, folks. So that again is your phrenic, while that is the vagus nerve. Vagus again is parasympathetic supply to the thoracic and abdominal area. It is the 10th cranial nerve. A phrenic comes from C3, 4, and 5. So remember we said C3, 4, and 5 keeps the phrenic alive because it literally keeps us surviving as it supplies the diaphragm. Okay, so these are two important kind of takeaways that we didn't really talk about when we were going over the slides, but they're really important, and this video illustrates it perfectly. So let's see, where were we when we stopped? So pretty much right here. Okay, so any questions before we hear him again?
Nope.
Okay, we're good? Okay, perfect. So
We'll look at the intercostal nerves and at the sympathetic trunk. Here are the vertebral bodies. Here's the proximal end of one of the ribs. Here are three of the intercostal nerves. They're the direct continuation of the anterior rami of the thoracic spinal nerves. They give motor innervation to the intercostal muscles and sensory innervation to the chest wall. They run closely with the intercostal blood vessels, which have been removed in this dissection. This slender, irregular cord is the sympathetic trunk. We won't go into a description here of the many functions of the sympathetic system or of its somewhat complex arrangement. The details that follow are shown on the premise that you've either just learned about these things or that you're just about to do so. The sympathetic trunk runs alongside the vertebral column all the way from T1 down to the sacrum. This thickening is one of the ganglia of the sympathetic trunk. These fine connections between the sympathetic trunk and the anterior rami of the spinal nerves are the rami communicantes. The nerves passing medially from the sympathetic trunk are the splanchnic nerves on their way to the celiac and mesenteric ganglia.
Okay, so, something just to keep in mind, like a takeaway from this guy here in this video, where, let me just get to the image. There we go. Is that, remember when we talked about the branches of the spinal nerve, we said that we mentioned that in the branches of the spinal nerve, we had a ventral and a dorsal rami, or a ventral and dorsal branch. And we said that all of our dorsal branches are going to, they're going to go into these plexuses to make a plexus, but with the exception of the thoracic ones. Okay, so we said that thoracic ones are just going to continue to become the intercostal nerves, and that's what you can see here. Those are your intercostal nerves. Okay, these splanchnic nerves and other things that he was talking about, those are not on your list, so they might be relevant to lecture, but they're not relevant to lab. Okay, so with that being said, how do I stop sharing this? Any questions about today's material before we go on to our kind of review of last week's material / quiz for today? Okay, seems like, when is your test? Is it like right after lab? Is that why everybody's just studying whatever else? 7:30 tomorrow, 7:30 in the morning, tomorrow morning? Okay, that's pretty early for a test. Okay. Well, let me share this then, and I could get out of your way. They don't care. Well, I mean, like I said, first 2 years, just, forget about them for a while. Just, it'll be gone and done with. Ask the other classes, they survived this, you'll be fine. Trying to figure out. Okay, so should I go in order? I forgot my pen and paper this week. Should I go in order, or do you want to claim structures? Oh, nice. No numbers on there. Perfect. So everybody's going to claim? Okay, folks. Okay, so it's up for grabs then. Who wants to claim what?
I can go on, I guess, a couple of the top structures. Not really sure how to, I guess, okay, starting on the right side. The
Okay, let me
first one.
point then. How about that? Okay, so what about this?
That's the head of the humerus.
Okay.
And that's the anatomical neck.
I can use a pen to circle them. Okay, now you're gonna make me do all the fancy stuff here. Let me see. Okay, does that work?
Oh yeah, that blue thing that you just circled is the greater tubercle.
Okay, what about this? Oops, you can't see what I'm pointing at. What about this?
Is that the surgical neck?
Well, the surgical neck would be kind of circle that whole thing where the whole thing surrounding it.
Is it the intertubercle groove?
Well, that's your other tubercle, I'm gonna guess, or is it this one? This image is really small for me to see. I'm gonna try to get a bigger image, at least for me, because I can't see them.
I think you can zoom in.
I was right, because the other one is the lesser, the other tubercle, the lesser
tubercle. Okay, so let me. Okay, I'll believe you, Tolo. I've got nothing against that. Okay. So. Okay. Yeah, I got the bigger picture.
Oh, okay.
Yeah, I guess you guys could take over and, do your own thing. Okay, so Tolo, I think you're good. Who is next? Oh,
I can give it a go.
Okay, go ahead, Michael. Take over. The slide is all yours.
So the one like under on the left side, under the circle and the line, is that the intertubercular groove?
Yes.
No. More up on the left. Yeah, that. Yeah.
Okay.
And
Yes, it
then
is. Okay, yes.
and then on the whole like the whole length of the the middle, that's a shaft.
Correct.
And then in the middle, that's the deltoid tuberosity. Should I answer more?
Yeah, just one more and then you're off the hook.
Okay, cool. And then bottom right, it's the coronoid fossa, that's pointing in the middle.
Okay.
Yeah,
So
that.
this
Yeah.
one right here? Okay. Okay, so thank you, Michael. Who else wants to claim the rest, whatever leftovers?
can
Go
go.
ahead, Mario. Okay, Mario, go for it. Mario, please go.
Sorry, I thought Anupam was gonna go.
Okay.
You can go if you want.
Okay. Sorry. Actually,
Well,
I'm a
let's
little.
see. I don't remember who said we could, kind of highlight our own things. So if you want to take over the slide and draw with that pencil or what have you.
Actually,
Go for it.
Anupam, you go for it. You go for it.
Okay, sure. So I'll go from the Michael talked about coronoid fossa. So I'll go from right to left.
Okay.
So number one that you marked is radial fossa.
Okay.
Then number two is lateral epicondyle. Then number three is condyle. Number four is capitulum.
Correct.
Number five is trochlea.
One more and then you're good.
And number six is medial epicondyle.
Correct. Awesome. I was doing the numbering. Thank you, whoever did that.
That was me.
Okay, thank you. Okay, so are we all good here on the humerus? We move on to our next slide. Okie dokie. So now, okay, so you're gonna number. Okay, go ahead, Rachel.
All right, can you hear me? All right, so number one is the trochlear notch. Number two is a coronoid process. Number three would be the radial notch. Number four is the ulnar tuberosity. Should I finish the right side?
Just one more.
Number five is the ulna.
Number five is the ulna, correct. Okay,
Yes.
perfect. Noah, do you still want to go? Noah, you have your hand up? Noah, are you
Can you
there?
hear me? All right, so number 6 is going to be the distal radio ulnar joint.
Yes, sir.
Number 7 is going to be so it'd be the ulnar head. And then number 8 would be the styloid process of the radius. Do you want me to keep going?
Yeah, so everybody do 5 and then we're good. We're good. So number 9 and 10.
That's the interosseous. And then number 10 is going to be the radius.
Radius, correct. Okay, perfect. Okay, Saeed, are you ready?
Yes.
Okay, go ahead.
11 is radial tuberosity, 12 is neck of the radius, and 13 is radial head.
13 is the radial head, correct. Okay, so you still have 2 more on the next one. Okay, so these are already numbered, which is great. Now how do we make this bigger, folks? Why do they do this to us? Zooming in, no zooming in. Okay, so
I think we can each individually zoom in.
Yeah, I'm trying to figure that out. Okay, well, if you guys know how to zoom in, that's fine with me. So number one, there's number one to that muscle, and number two is this muscle right here. Okay, so Saeed, you still got two more to go.
Number one is deltoid, and two is bicep, I think.
Biceps, you're absolutely right. Correct. Okay. Mario, do you still have your hand up, or are you having second thoughts?
I'll give it a go.
Okay.
Is 3 asking for the nerve?
That is a good question. For somebody who can barely see what it's asking, it is actually going for the two heads of biceps, which again is not on your list. So let's ignore those.
Okay.
But if you want to know,
Isn't that short head
ahead.
and then 4 is the long head? Or no?
It's the opposite.
Oh.
Long head and short head. Again, it's not on your list, so I'm not going to worry about it for now.
Okay.
So biceps is fine. Okay, 5 and 6. Hopefully you're able to zoom in because this is really challenging my eyes right now.
Is 5 the
5's
intercostal
right here.
or intercostal muscle? Serratus anterior.
It's the serratus.
Okay.
Okay,
And
number
then
6.
that's the pectoralis major.
Yep. 7.
And then that's the brachialis.
It is brachialis, correct.
Okay.
Yep. Next one. So how many did you answer? I think you still have 2 more to go.
Yep.
Okay, so 1 and 2.
That's deltoid and trachea.
Correct. Yep. Okay, next one. Who wants to do 3 and then 1 on this bottom, on the bottom image? Okay, Noah?
So 3 would be the brachialis,
Right.
and then 1, is that like the subspinatus? Wait, no. The list real quick from lab. Or you can pass it to somebody.
Okay, any other takers, folks, on that one?
Is that the Paris
Scapularis, and somebody remind me, was that on your list or not? Because I don't remember if it was. But it's the subscapularis, which is on it's a muscle that covers the subscapular fossa. Okay. So number 1 is the subscapularis muscle. Okay. Now this right here. Okay, go ahead, Michaela.
Number 1 is the supraspinatus, and number 2 is the infraspinatus.
Correct. And what about number 2 here on the other one? Okay, 1 or 2, whichever one you can identify.
It's number 2, the teres major.
Number 2 is the teres major. You're correct.
Okay.
Okay, what about number 1? If you
I'm not
want to pass.
sure.
So we'll pass. Any takers on that? It looks like it's coming up from up here from the scapula, okay, from the coracoid process of the scapula and going down towards the arm. I'll get to that in 1 minute, Mario. So do you actually have your hand up, or is that from an old question? From a previous question? I can try to answer one. Okay, go for it.
Is that the coracobrachialis?
It is the coracobrachialis. Yep. Okay, answering your question regarding teres minor and major, remember that teres major was the one on the bottom and teres minor was the one on the top. So this one is coming all the way from the bottom of the scapula. Teres minor would be above it.
Oh, so no room for another muscle to go underneath it. That's how you can kind of differentiate. Okay. Sounds good. Thank you.
Now for this one right here. Okay, who did not answer yet? So I think Haun didn't answer. Rachel, did you answer? I think you did. I'm not sure. But I know that I'm missing a couple of students that haven't answered yet. So if you have not, claim you got 2 more slides to go. Claim one of them and go for it. You did? Okay, that's what I thought. I just wasn't sure. Haun, you want to go for it? Is it just me? I think so. You're not going to do all of them, you know. Oh, there are only 5. Do this slide or the next slide. Just let me know which one you want to claim.
Can I do the next slide?
You want to do the next slide? That's fine. Yep. First off, when you're looking here, just a little tip as where is medial and where is lateral. This is medial because this is that medial epicondyle a little bit more. So now you could know that this is medial and that is lateral, and that helps you identify these veins. Oops, I was supposed to say that, was I? Oh, wait. Oh, well. So try to identify these blood vessels then.
Okay. This is so hard. Okay, number four basilic vein.
Number 4. Let me go back and see. Number 4, this one?
Is that the basilic vein?
That is a vein that connects the basilic to another vein. Let me just give you a hint that 1 and 2 are really the same vein. Okay, so remember we said that there is a vein that will connect the basilic to another. And we said that the basilic would be towards the base, like towards your armpit, while the other vein, or I'll just name it, the cephalic vein would be more towards the head. Okay, so these are your 2 veins right here. This is the medial epicondyle. Keep on going all the way, you know, upwards. That would reach your the axillary area. So this right here is the basilic vein. Okay, 1 and 2 are both actually the cephalic vein. And then there's the vein that connects them together that was the median cubital vein.
Oh.
Okay, so let's try another one. Want to try to go for another one?
Which one?
It's up to you. We only got this one and this one.
Let's see.
How about?
I'm sorry.
Oh, that's okay. That's fine. That's fine. So how about the muscle that makes the contour of the shoulder?
Deltoid.
Correct. Yep. How about the? Can you identify any of these? Muscle that goes from the medial border of the scapula all the way up. There are 2 of them, one of them on the bottom and one on the top. If not, that's fine. We'll come back later, okay? Okay, go for it, Mario. Okay, we'll just go, we'll come back to things later. Okay, Mario, can you identify one? Since you got, or did you have a question?
Yeah, I can go. Is 1 the rhomboid major and 2 rhomboid minor?
1
Or
and
no?
2, rhomboid major and rhomboid minor, correct? And then you have 3.
Is that the, I want to say levator scapulae, but is that wrong? Is that right?
It's not wrong. It's correct. Yeah.
And then,
We already have the deltoid. That is correct. And then number 4, the muscle
the
above the
super-
spine. That's a super. Okay. Now for these little structures down here, we have a blood vessel and there's a nerve. Okay, so 1, 2, and 3, those are blood vessels, and you can see a blood vessel kind of dividing into 2. This is found in the arm area, so this is the elbow. So any guesses as to what blood vessel would be down in the elbow and then divides into the forearm into 2 other blood vessels, 2 other arteries? Let's see who else is down here. Okay, Noah?
Brachial artery, which branches into the radial artery and the ulnar artery.
Right, so which one is radial, which one is ulnar, 2 or 3?
Radial would be 2, and 3 would be the ulnar.
Yep, so we're, again, looking at that medial epicondyle that is more prominent than on the lateral side. So this is medial. So number 3 would definitely be your ulnar artery, and 2 is your radial artery. Okay, what is that nerve, that annoying nerve that gets hit? And we call it the funny bone. It's nothing really funny about it, but it is found behind your medial epicondyle. Okay, Michaela?
Is it the median nerve?
It is your, oh my.
Is it the median cubital vein? No, sorry, no.
You're right, it's the median nerve. Whoever said the median nerve is correct. So that was you, Michaela, right?
Yes.
It is the median nerve. It's a white structure, so that would be a nerve. You can see here what the veins look like. They're darker in color because of the deoxygenated blood. Okay. Okay, so that kind of ends, what I've had for you guys for today. Any questions, folks? I think this quiz is already up there on the OneDrive for you guys, so you already have access to it. And like I said, every week I'll just keep on adding stuff on there. Okay, are we all good? Yes, no, maybe. Yes, Mario. See, okay, so you're good? Oh, okay. Okay, so if everybody's good, I will see you folks next week then. Good luck on your exams, people. Good luck.